study hypertension. It's a very, very vast topic. There is no way I can cover everything in an hour. So I just want to make sure that you guys understand the basics, and then we'll address any questions about the specific topics that we covered today. So just to give you a scope of what hypertension is in terms of the enormity of this disease. It's actually the second most important risk factor for cardiovascular disease. Does anybody want to guess what the first risk factor or the most important risk factor is for cardiovascular disease?
Smoking?
That's absolutely right. So smoking, right? That's the biggest issue. But then right after that, following as a close second is hypertension. And then depending on how we define hypertension, it ranges between, a definition of greater than 130 over 80 versus 140 over 90. The prevalence is anywhere between 32 to 46%. So that's a huge, almost 50% of the population, if we consider a cutoff of 130, has hypertension. And then even, we should not really start to kind of relax at the age of 50 saying, hey, I've never, not been diagnosed with hypertension yet, and I probably won't be. And that's actually a false thought. About 90% of the people after the age of 55 have a lifetime risk of developing hypertension. So that's when you kind of have this heightened sense of screening and making sure that you're diagnosing those people in the right time frame. And then this is one of the most modifiable risk factors for cardiovascular disease and deaths as a consequence of hypertension and cardiovascular disease. And basically, in a meta-analysis that studied about 61 prospective studies back in 2002, so we must have much more data now, but back then it actually showed a double risk of death from stroke, heart disease, or any other vascular disease if a person's blood pressure is sustained 20 millimeters of mercury above baseline, which was defined as 120, and 10 millimeters for the systolic blood pressure, and 10 millimeters of mercury higher than the baseline, which was defined as 80. So anything over 140 over 90 would put you at 2 times at a higher risk for death from stroke, heart disease, or any other vascular disease. I know everybody has gone through the pathophysiology of hypertension at this point, but what I really wanted to emphasize on is if you just look at this diagram, you'll figure out how many organs are actually involved. It's a very complex disease when it comes to its physiology, because there are genetic and environmental factors that have a role to play, and then just going through the physiology from the very basics. When your renal perfusion reduces, so if there's a defect in renal natriuresis, renin is released into your bloodstream, which converts the enzyme angiotensin, which that is released from the liver, into angiotensin 1. This then travels through your lungs, and then ACE, which is the angiotensin converting enzyme, is released to the endothelial lining of your lung, of the capillaries in your lungs, and that converts angiotensin 1 to angiotensin 2. And this right here is what drives most of the effects of hypertension. So when you talk about its effects on veins and arteries, it causes vascular constriction overall. Blood pressure, as we all know, is a product of systemic vascular resistance and cardiac output. So when you have vasoconstriction, you're actually increasing the preload to your heart, and by the Frank-Starling law, it kind of increases your cardiac output. And then if you cause arterioconstriction, it just causes worsening total peripheral resistance, which also increases your blood pressure. So that's one effect of angiotensin 2. The other is it goes and tells your adrenal cortex to release aldosterone, which then causes sodium and water retention, and then that causes increased intravascular volume, and then that also contributes to increased cardiac output, again causing increased blood pressure. One thing that I found very interesting, it was kind of a revision for me, looking at the physiology. When you are in a persistently acidotic or hypoxic state for a long period of time, your peripheral and central chemoreceptors start to sense that, and that also causes, there's a complicated pathway where it goes to your nucleus solitarius in your brain, and it tells your body to kind of amp up the blood pressure. But this kind of a persistent state of hypoxia or acidosis can cause a patient to develop hypertension or put them at risk for hypertension. And then, of course, if there are any defects in your smooth muscles, there are issues there, and then there are genetic and environmental factors that kind of raise the set point of the homeostatic set point for your body to find that higher blood pressure to be the new normal, and then it kind of works to maintain that higher homeostatic normal. This is a very basic slide. We've all measured blood pressure at this point, but I thought it would be fun to think about how you would recognize systolic blood pressure when you're doing an auscultatory measurement. So what are you looking for when you're marking that systolic pressure when you're using, checking blood pressure? Anybody wants to take a shot at that? Exactly. So you listen to the first Korsakoff sound, right? That marks your systolic blood pressure. Diastolic blood pressure is pretty much when, but it stops, and it's actually called the fifth Korsakoff sound, which I did not know. I just thought it just disappears. But the next thing is pulse pressure, right? So do you know how to measure pulse pressure based on these two values? How would you know what the pulse pressure is? Look at it, you guys know everything. I don't need to tell you much. But how about MAP? How do you calculate MAP? So yes, but there's a very simple way of remembering that as well. That is, your diastolic blood pressure kind of remains constant throughout the cardiac cycle. So that's an entity that you keep to yourself. Like the diastolic blood pressure is basically the same for the 0.8 seconds that your cardiac cycle lasts for. What you're adding onto that is 1/3 of the pulse pressure. That is the difference between the systolic and the diastolic blood pressure, to kind of even out the excess pressure that's measured in the systolic time frame, which is basically 1/3 of your entire cardiac cycle. That's the logic behind this formula. So I just find that easier to remember, that it's diastolic blood pressure plus 1/3 of the systolic blood pressure minus the diastolic blood pressure, which is the pulse pressure. And then mid BP is something that we don't really use in clinical practice. I mean, I've not really used that very much, but it's just the sum of the diastolic and systolic blood pressure divided by 2. Okay, this is a very fun slide. I wish Dr. Bartmus was in this room right now, because he would really reinforce this. But this is how you check blood pressure. I can tell you, I have probably checked blood pressure once in my life, keeping all of these factors in mind. In the office setting, the patient should be seated, back upright, feet planted on the floor. The mid arm is supposed to be at the level of the heart, hand is relaxed, your cuff is the appropriate size, and then the patient is not supposed to be telling you about the weather during this time. There's no time for chit chat. You're actually just taking their blood pressure. And then they should not have had coffee, they should not have smoked prior to that, like about 30 minutes or so. No exercise 30 minutes prior to that. They should be having an empty bladder, should have had 3 to 5 minutes to relax. And then you use an average of 2 measurements, and typically you take 3 measurements 1 minute apart to get a good idea of what the blood pressure is at. How many people in this room have done this ever? We don't do that, right? And we very easily label patients as hypertensive based on readings that are not conducted in this kind of fashion. And honestly speaking, it's sometimes not practically possible, but it's important to kind of keep that at the back of your mind when you're, diagnosing somebody with hypertension, especially for the first time. Talking about blood pressure categories. Now, I want to emphasize that my presentation is primarily derived from MIXAP, which is a resource we use when we're preparing for our IM boards. And then the ACC-AHA guidelines that were published in 2017, and they are actually the most updated guidelines that are available to us. There is an International Society of Hypertension statement that was released in 2020. Most of the recommendations are the same, but there are some differences, and though I've not gotten into those nuances, I've just focused on the ACC-AHA guidelines and what ACP recommends, okay? So based on that, elevated blood pressure is defined as a blood pressure of anything between 120 to 129 mmHg, and anything less than 80. Now once you cross that level of 130, ACP and AHA defines that as stage 1 hypertension. And then stage 2 is 140 over 90 or higher, and then hypertensive crisis, which is what we're going to talk a lot about at the end, is a blood pressure greater than 180 over 120. And talking about screening guidelines, and this is taken from the USPSTF guidelines that we have currently available. So they say that any adult 18 years of age or older should have one office blood pressure measurement. Once you have a blood pressure measurement that is higher than normal, you need, in the office, you need to confirm that with an out-of-office blood pressure measurement to make a diagnosis of hypertension, right? This is the exception to this kind of rule is if you have an extremely high blood pressure, 180 or 110 in the office, and the patient has risk of cardiovascular disease or is at risk for it. That's when you have like a shared decision making, and you kind of address that earlier than just waiting for a couple of weeks to recheck that blood pressure. You need to annually check blood pressure for any adult aged 40 years or older, and any adult that is at an increased risk of hypertension. And then anybody between 18 to 39, you can check every 3 to 5 years, but depending again on your patient and what their risk factors are. I think this is not something that we really typically worry about, because when somebody comes to the office, they automatically get a blood pressure reading. So this is not something you really need to keep, focus that much on. And then if anybody comes to your office and they're at 135 over 85 and they're like, hey doc, let me make some lifestyle changes, I'm going to work on my diet, whatever. You don't say, okay, I'll see you next year, have a good life. You want to see them back in 3 to 6 months. You want to check that blood pressure again and see if that helped. And then you want to make sure that the out of office measurements that are taken are with validated devices, and either you can, depending on their risks, prescribe ambulatory blood pressure monitoring, or you just tell them to check their blood pressure at home, right? So when you're talking to a patient for the first time and they're being diagnosed with hypertension, what are some things, and it's here, but I just want to hear your thoughts as to what are some things you want to ask the patient and why? Great, right? So that puts them at a higher risk for developing hypertension. What else? So for instance, if I were to ask the patient about chest pain, shortness of breath, or palpitations, what am I looking for? Why do I want to know these things when I'm talking to the patient? They have high blood pressure and I want to know if they have chest pain, what am I thinking about? Right, so any cardiovascular issue that they might have, right? Have they developed heart failure, or have they developed, angina or something like that, right? Peripheral edema again goes along the lines of do they have diastolic heart failure with reduced ejection fraction and things like that. Why would I want to know if the patient has muscle weakness, cramps, things like that?
Electrolyte imbalances.
What could cause electrolyte imbalances in a patient who has hypertension?
Hyperaldosteronism.
Exactly. So if they have primary hyperaldosteronism, they can have these kind of symptoms, and that might be their primary complaint. And then if a patient has concerns for Cushing syndrome, you can look at weight gain, menstrual irregularity, hirsutism, truncal obesity, and sometimes when we see such a patient for the first time, we're like, okay, your obesity is probably driving your hypertension or things like that, But if you look at the entire clinical scenario, you can kind of figure out if this is a syndromic issue. And then one thing that we should keep at the back of our mind is if a patient has recurrent flash pulmonary edema, think about renal artery stenosis and evaluate the patient for something like that. Again, things like pheochromocytoma would present with sweating, palpitations, headaches. OSA would have snoring, excessive daytime sleepiness, and I'm oversimplifying these symptoms. There are obviously more things you need to ask, but these are just some of the preliminary things that you can think about when you're evaluating a patient for hypertension. And of course, anybody with hypo or hyperthyroidism are at risk for hypertension, so that's another thing that you kind of look at. When you're talking about cardiovascular risk factors, I want to mention that we're talking about things like diabetes, elevated LDL. You're talking about hypertriglyceridemia, obesity, hyperuricemia. So it's not just diabetes and you call it a day. There's a couple of things that you need to watch out for, and then smoking, alcohol intake, and things like that. So your initial lab tests, right? This is, I think, fairly basic and something that a lot of patients when they initially present to the office for a regular evaluation as well. So you're looking for kidney function disturbances there, you're looking for, if they have diabetes, you're looking for hypertriglyceridemia and LDL elevation, thyroid issues. And then it's very important for us not to miss this one, the urine albumin creatinine ratio, because the degree of albuminuria that the patients have actually dictate what are the recommended first-line medications that we use in these circumstances. So that's important to evaluate. And then of course getting a baseline ECG is a good idea. And does anybody know why we would want to do that? Just get an idea of what the baseline EKG looks like.
And they can get like ventricular hypertrophy or things like that.
Exactly, excellent. So if suppose it's normal and then I check it 6 months later and the patient's blood pressure is elevated and it's, they have evidence of left ventricular hypertrophy, we're concerned about that, right? And then that's when things like an echo come into play. So a person that comes in with a hypertensive disorder, you don't necessarily need an echo at that time, but if you have evidence of something like left ventricular hypertrophy, and you have an abnormal cardiac exam, that's when you want to think about that, okay? And then, not going to spend a lot of time on this slide, but I want to draw your attention especially to caffeine and decongestants here, because a lot of the times patients would have consumed caffeine shortly prior to coming to the office, or sometimes in allergy season, they've been taking decongestant medications or using local decongestants, and unless you ask, they might not tell you, and that would be probably a driving factor behind that elevated blood pressure reading in the office. Of course, we know amphetamines are no good for you, so if a patient is doing them, ask them to stop. And then oral contraceptives, NSAIDs, these are also commonly used medications that you want to make sure you're asking patients about this, because oral contraceptives cause more sodium retention that can drive some degree of increased renin-angiotensin system activity, and then NSAIDs do the same thing, so they can do drive hypertension as well. And then these herbal supplements, right? I take a bunch of herbs. Which ones? Are you doing ephedra? Stop. Things like that. You just need to kind of ask your patients. Now. High blood pressure or hypertension is a very silent disease. Patients are not going to feel any symptoms of high blood pressure unless they start affecting end organs in some ways. So the end organs that are most commonly involved in hypertension, going from head to toe, are of course the brain, right? And things that you're worried about are small strokes over a period of time that go undiagnosed, and that can lead to dementia. More importantly, ischemic and hemorrhagic strokes as a consequence of uncontrolled hypertension. You could have, cotton wool spots, retinal hemorrhages, papilledema, which is a sign of end organ damage. The heart has a bunch of things that can, hypertension can make things go wrong in a big way. So diastolic dysfunction, heart failure with reduced ejection fraction, acute MI, accelerated coronary arteriosclerosis. All of these things, which we see very commonly, one of the biggest risk factors is hypertension, right? And then with kidney, you have, by the mechanism with which hypertension works and the homeostatic changes that happen in your body, your GFR reduces for a certain period of time within your nephrons, and that can cause, again, a whole sequelae of more long hypertension based on, when the GFR is reduced in your renal system, it tells your body, hey, we don't have enough fluid in the system and we need to retain more, and that kind of just keeps driving the same force forward. And then chronic kidney disease, and then end-stage renal disease, which of course leads to dialysis, and that's kind of a sequelae of uncontrolled hypertension. And then you can have aortic dissection, which is it's a fatal end organ damage. And then you can have aortic aneurysms, which can be either ascending or descending in the system. Okay. So when the patient initially comes to you and they have elevated blood pressure or stage 1 hypertension, what are some of the non-pharmacological interventions that you can recommend to patients at this point?
Diet and exercise.
Diet and exercise, right? So is there a specific kind of diet? DASH. Okay, does anybody know what's the full form of DASH? I asked because I had to look it up too. Dietary approaches to stop hypertension. That's what DASH is, right? So that's basically a diet rich in vegetables, fruits, nuts, low in sodium, high in potassium. So that's the DASH diet. How much of a difference do you think the DASH diet can make?
10 to 15, 5%.
5%.
Let's see. So it almost makes a difference of 10 points. And with this, if you also lose weight, you're losing about 5 points on your blood pressure. So both of these interventions are very important. What is the sodium level that you're aiming for in these patients? Like what, I mean, when I say that sodium intake, what do you tell them? How much do you limit your sodium intake at?
2 grams?
So actually, the guidelines recommend 1.5 grams. We typically tell patients 2 grams, but 1.5 grams is where when you're asking them to make these lifestyle changes, that's where you want them to stop. And then how much potassium do you want them to have in their body, like intake, a daily potassium intake of how much? So about 3.5 to 5 grams. You tell them to take a very rich potassium diet, and that helps as a non-pharmacological intervention. So when you tell a patient to exercise, what do you want them to do?
Walk.
Okay.
Do like 150 minutes a week.
Walk for 30 minutes.
Okay. So if I take a stroll in my apartment complex for
Heart rate
150 minutes,
should be
80%.
65 to 70%. So you want to challenge your heart to a heart rate of about 65 to 75%. So aggressive cardiovascular exercise, 90 to 150 minutes in a week. And then when you're talking about isometric or dynamic resistance training, you're wanting them to do, it's very specific, 6 exercises, 3 sets of 10 repetitions each, right? And you want to do that twice a week. So that's a very specific kind of instruction that you can give your patients, right? And then when a patient is drinking alcohol and you're wanting them to stop or reduce their intake, what are you asking them to do? I mean, what direction do you give them? How many drinks a day can you drink? What is a drink?
For men, is it 2 units? 2 units a day?
Yes, and for women?
Women, 1.
So 1 or less and 2 or less for men. What is a drink? So if I take a whole big bottle of vodka and say that's my drink for the day, is that I just had 1 drink, doc. It was my bottle of vodka. What is a drink?
Like 1 shot.
1 shot, okay, 1 specific. What else? 30. So yeah, it's actually 12. Don't be that mean to your patients. It's 12 ounces of beer. Okay. So a drink is 12 ounces of beer, 5 ounces of wine, and 1.5 ounces of distilled spirits. That's 1 drink. So when they have 2 servings of this much, that's enough for the day, okay? And so this is the kind of change you expect with, low sodium, high potassium diet, physical exercise, etc. So you can see it is quite a change. If it's just mildly elevated, you can probably fix it with just these changes, right? All right. So talking about pharmacological therapy. If you give a patient antihypertensive medications at the right time in the course of their disease, you're reducing their risk for stroke by 40%, MI by 25%, and 50% reduction in heart failure, right? And then it's not important to fixate on what agent in most of the population unless they have specific comorbidities. The agent is less important than the fact that you need to control the blood pressure. Okay, so that's another important takeaway. Now, when do you recommend non-pharmacological treatment alone versus when do you add medications? And that's a good piece of information that we need to have. If it's just stage 1 or elevated blood pressure with an ASCVD risk of less than 10%, just non-pharmacological therapy alone is enough. Just that intervention and then recheck in 3 to 6 months. If the blood pressure is in the stage 1 hypertension category and the ASCVD risk is more than 10%, you want to add drug treatment to the non-pharmacological therapy, right? And then your BP goal is keeping it less than 130/80. If the patient has no cardiovascular disease risk factors or it's less than 10%, and they have stage 2 hypertension, you still do the non-pharmacological management along with drug therapy. You use a combination of 2 first-line drugs if their blood pressure at the time of diagnosis is 20 points higher than the normal in the systolic range and 10 points higher than normal in the diastolic blood pressure. And that's when you choose 2 agents from the first-line categories. And we'll talk about what are the first-line drugs. And then there's a little bit of a discrepancy on what is the goal blood pressure for patients who are 65 and older between ACC, AHA and ACP. So ACC, AHA says that you target 130, systolic blood pressure less than 130 regardless of whether they're over 65. ACP actually recommends a target blood pressure of less than 150 in anybody that's greater than 60 years of age. This again is a very nuanced discussion with your patient. It's very personalized based on their own individual risk factors, their tolerance of the medication, etc. But this is the general guideline that we have in place to help direct therapy. And then anybody that has diabetes along with hypertension or who has CKD, with hypertension your goal is less than 130. Initially, the ADA used to say if the ASCVD risk is more than 15%, less than 15%, etc., things are different. But now ADA as of 2022 says less than 130 is where you want to be diabetes and hypertension. I've already mentioned this to you. This is an important point. So when I mentioned urine albumin creatinine ratio needs to be measured on an initial encounter, any urine albumin creatinine ratio more than 300. The recommendation is to start an ACE or an ARB at maximum tolerated dose for these patients and maintain their blood pressure less than 130/80. However, it's not as strongly recommended if the urine albumin creatinine ratio is between 30 to 300. So it's less emphasized in this range. The KidGO guidelines are very strict about their blood pressure controls, and this is the kidney guys. They say keep the blood pressure less than 120 if the patient has hypertension and CKD. Carbs are recommended in presence of proteinuria. Now, when you start a patient on ACE inhibitors or ARBs, you want to check their potassium and their kidney function. Because of the physiological effects of an ACE inhibitor, you would expect a 25 to 30% rise in their creatinine. But anything above that, you want to be wary of these drugs, and you also should consider screening the patient for renal artery stenosis in these patients if the creatinine comes up a whole lot upon starting these medications. Alrighty. So our first line medications, it's very simple, 4 classes. Just remember 4 classes. Thiazides, ACE inhibitors, ARBs, and calcium channel blockers. Those are the 4 classes that serve as our first line drugs when initiating antihypertensive drugs. Initially, there was a preference for chlorthalidone because people believed, there's cardiovascular benefit. Recently, this has been debunked by the diuretic group. There was a study done and it was published in NEJM. So this is no longer a preference, except it has a longer half-life. So for that reason, you want to use it, great, but there is no cardiovascular benefit in comparison to hydrochlorothiazide. Of course, you need to check for hypokalemia, hyponatremia, and all of those things in this class of medications. These are crowd favorites, and ARBs are more, I've seen in clinical practice a lot of PCPs prefer starting patients on ARBs because they have a better side effect profile, especially with the chronic cough that patients experience with ACE inhibitors. So now I've seen patients being started on an ARB more frequently than an ACE inhibitor, but either of these are perfectly acceptable. Of course, if a patient has had allergy to ACE inhibitors like angioedema and such, then when you're switching them over to an ARB, you need to give a period of 6 weeks before you start them on an ARB, but they are eligible for an ARB therapy even if they've had angioedema with ACE inhibitors. And then with calcium channel blockers, we start and end with that amlodipine in clinical practice pretty much when we're talking about hypertension. But any of these medications are first line. All of them are. This is just, it becomes a little bit of a discussion. If the patient has heart failure, you want to avoid using diltiazem in such patients. And then, of course, they cause bradycardia, so their side effects are a little bit different than amlodipine. This is generally more tolerated and safer drug, except that it causes a lot of pedal edema, can cause some constipation, but otherwise quite well tolerated and has a good, effect on high blood pressure control. I just wanted to show you guys All of these first-line medications are available in Walmart for $4. So there is no reason for a patient to say they cannot afford it. If they cannot pay $4, they're available for free at Publix. So please send them and use these resources. Make sure that they're aware that there is no good reason for them to be non-compliant. Okay. And then again, even Olmesartan at Publix is like $16 for a 90-day supply. So it's fairly affordable. And we should know these things as physicians so that we can address the socioeconomic challenges that a patient may face. This is just a diagrammatic view of everything we've already talked about. What you would do when a patient has elevated blood pressure, stage 1 hypertension with a higher ASCVD risk versus lower ASCVD risk, and then stage 2 hypertension. We've already kind of talked about it, but this is just a good place to look at that as a snapshot. So this is a big part of, this is towards the end of the talk, but it's something I wanted to emphasize on more. That is management of inpatient hypertension or acute severe hypertension. Acute severe hypertension by definition includes any blood pressure greater than 180 over 120 with or without end organ damage. Okay? Either. When it's with end organ damage, it's hypertensive emergency. When it's without end organ damage, you're talking about hypertensive urgency. And that's how you break that down. You will see a bit of both in the inpatient setting. So, 4.6% of our total ED visits have acute severe hypertension on presentation. And most of the patients are 60 years or older, underinsured, and then the black population is more affected. Hypertensive urgency does not cause worse short-term outcomes. It has worse long-term outcomes. So there is no rush whatsoever to fix that blood pressure within 30 minutes of presentation. We don't need to rush to IV drugs with hypertensive urgency. That the discussion for hypertensive emergency is entirely different. So you want to be very careful with either urgency or emergency as to what pace you're decreasing the blood pressure at, because you're going to hurt the patient even if you decrease the blood pressure too quickly. So you want to make sure that even in either circumstance you want to be very careful with that. Now, this is because when you're talking about chronically elevated blood pressure and uncontrolled hypertension, in your brain, your autoregulatory systems have shifted to the point where they're used to that higher blood pressure. If you cause a precipitous drop, you're going to cause a stroke, you're going to cause acute kidney injury, you're going to cause myocardial infarction and such. Okay? And then if the patient is non-adherent and they have hypertensive urgency, the only thing that you need to do as the first line thing is to resume their home medications. Right? And that's why it is one of the most common leading causes of acute severe hypertension. It's just that you're not taking the medication, so what else do you expect is going to happen, right? In hypertensive, acute severe hypertension, if any of these end organ damages are present, that means if they have a stroke, they have papilledema, acute coronary syndrome or heart failure, aortic dissection, AKI, and rarely do we see microangiopathic hemolytic anemia in such patients. If you see any of this is a class 1 recommendation to put the patient in ICU. You need to make sure they go to the ICU, they get their IV drugs started, and the drugs are selected according to whatever problem they have come with, right? And then you want to make sure you start long-acting drugs within the first 6 to 12 hours of their presentation, so that you wean them off the IV drugs and then they're controlled on their oral medications. However, if they don't have all of this, you can actually just check the blood pressure after 20 to 30 minutes, and you see if the blood pressure is still high. Then you want to, and the patient is symptomatic from that high blood pressure, you can give a rapid-acting oral agent. Something like clonidine can help in such a situation. And then you can also give things like Lasix. That's what Mixap suggests, but you don't have to unless they're symptomatic. You can actually just adjust their long-acting medication and slowly see how their blood pressure comes down in 1 to 7 days. And looking at the hypertensive emergency patients, like I mentioned, it's a class 1 recommendation to admit them to the ICU. There are 3 circumstances in which you want to bring the blood pressure down rapidly, which I will emphasize on in this slide and again later because that's very important. One is aortic dissection. You want their blood pressure to come down less than 120, pretty much within the first hour of presentation. Severe preeclampsia or eclampsia, the goal is less than 140, again within the same kind of duration. And then the same thing applies for pheochromocytoma crises, okay? And otherwise, now this is again a point of debate, and I think Bakar and I have had this debate in the past. That is, are we reducing the systolic blood pressure by 25% in the first hour, or are we targeting the MAP in the first hour when we're reducing blood pressure? The answer is not simple because as you can see here, ACC and AHA recommends reduction of systolic blood pressure by about 25% in the first hour and then to 160 over 100 over the next 2 to 6 hours. When you look at UpToDate or you look at some other resources, they actually talk about reduction of MAP by 10 to 15% in the first hour and then by another couple of points in the next 2 to 3 hours, and then you come down more slowly to 160 over 100 over the next 23 to 24 hours. So I think it depends on a patient-to-patient scenario. I asked cardiologists about this. They said sometimes it equates to the same thing, systolic blood pressure reduction and MAP reduction, but I would just say that it's a case-to-case basis how you want to approach that. And I've already mentioned that your hypertensive urgency does not require the knee-jerk reactions that we usually give it. So you can actually adjust their oral medications. But one thing that you want to keep in mind when you're treating these patients in the inpatient setting is you're looking for pain, you're looking for volume overload, you're looking for urinary retention, alcohol withdrawal, and agitation as primary sources of driving that hypertension. If you fix that problem, their blood pressure may improve and you may not have to do anything else. So that is a very important consideration in the inpatient setting. As far as hypertensive emergency is concerned, we've already talked about the time at which we need to reduce blood pressure and by how much we need to reduce it. But we're going to talk a little bit about more common presentations of hypertensive emergency. For example, if a patient comes with intracranial hemorrhage, it is actually harmful to reduce the blood pressure less than 140. And when you're reducing the blood pressure, you want to use an IV medication which titrates the blood pressure very, very evenly over a period of time and reduces it in a more controlled fashion. So that's something that you need to keep in mind. The other thing is with an acute ischemic stroke. Now, when a patient presents with an acute ischemic stroke and their blood pressure is more than 220 over 110 and they're eligible for TPA, what do you want to do? Exactly. So you give them medications to the point where it comes down below 185 and 110, which is where you give the TPA, send them to ICU because their blood pressure then needs to be maintained below 180 over 105 and they will probably need IV medications to maintain that. If they have not been given TPA, do you need to act on the blood pressure greater than 180 over 110? What blood pressure do you need to do something about?
More than 220.
More than 220 over 110, right? And then it's actually a class 2B recommendation. That means it's not very strongly recommended, but you reduce the blood pressure about 15% in the first 24 hours if it goes above this point. You can actually wait 48 to 72 hours if the blood pressure is remaining below 220 over 110 in strokes to bring the blood pressure down a little more slowly. Again, this has to do with your cerebral autoregulation and the higher set point that your brain has now imagined it's at, right? So you need to bring it down more slowly.
So it's studied that use 42 hours they can sustain.
So anything less than 220 over 110, it says initiation or reinitiation of antihypertensives can be done within the first 48 to 72 hours. So you don't need to do it urgently within the first 24 hours. And this basically just talks about preferred drugs for certain conditions. A thing to keep in mind for acute aortic dissection, a big thing to keep in mind is beta blockade. Block their beta receptors as soon as they come in. Give them esmolol, give them labetalol. Because if in the attempt to drop their blood pressure you give them a vasodilator, and they have reflex tachycardia, you're going to kill them basically, because it's going to increase the shearing force on their arteries from tachycardia. And for that reason, it's important to block their beta receptors first and then add whatever other medications you want to add to further reduce the blood pressure to reach this aim. For eclampsia and preeclampsia, because the patient is pregnant, you have limited resources you can use. So hydralazine, labetalol, and nicardipine are preferred drugs. And nitroprusside, ACE inhibitors, and ARBs are actually contraindicated in these patients. In pheochromocytoma, there's a lot of alpha and beta activity happening in the body. Therefore, phentolamine is a good choice, clevidipine is a good choice, and nicardipine is a good choice in these patients. And for acute pulmonary edema, nitroglycerin, nitroprusside, and clevidipine are good choices. Beta blockers are contraindicated in an acute episode of pulmonary edema for the first time, especially an IV medication.
Are they contraindicated in pheochromocytoma as well?
Beta blockers, I did not come across that information, but
Probably.
I don't
know,
but you have to block
Unopposed
the alpha first.
yeah, unopposed, maybe yes, using them in without conjunction with other blockades, yes, because it's both alpha and beta action. ACS, you want to use esmolol, labetalol, nicardipine, and nitroglycerin. You want to avoid nitrates with PDE5 inhibitors, otherwise you'll bottom out their blood pressure. And then AKI, the drug that you can use other than the common ones is phenoldopam, because that actually works on the dopamine receptors in the renal cells and helps improve renal blood flow. So those are just some exceptions to the common medications that we use. And then one thing to remember, this is a very commonly used drug. When you actually start practicing, Cardine or nicardipine is a very commonly used IV medication to control blood pressure. It is contraindicated in severe aortic stenosis. So know that about your patient. And let's see, hydralazine is very unpredictable, very commonly used, but very unpredictable in its action. So if you can avoid it. There are better options available most of the time. It's quite often added to help wean off of these IV drugs in the ICU, and sometimes it's used in a scheduled fashion for that, but for long-term IV use, it's not the best option. And then, let's see. I'm not going to spend a lot of time on these because you're not going to really use them very much, except labetalol. It is contraindicated in asthma, COPD, heart block, and can worsen heart failure, so just keep that in mind. This we use a lot for patients that come in with uncontrolled atrial fibrillation and such, now more frequently used in those patients. But you want to avoid precipitating bradycardia. There's also concurrent other beta blocker, calcium channel blocker therapy, pulmonary edema, or severe heart failure. Okay. So that's pretty much the drugs that we use. For the questions, if you guys could pull out your phones, because you're going to have to text a number and then we'll have a little poll. But one of you guys, if you want to take the question and read it out loud for everybody. Any of the med students want to take a shot at just reading the question? The answers are all confidential.
Okay, a 62-year-old man is evaluated in the emergency department for abrupt onset of sharp chest pain relating to his upper back that started 90 minutes ago. Medical history includes difficult to control hypertension, hyperlipidemia, and type 2 diabetes. Medications are metformin, empagliflozin, rosuvastatin, naltrexone, hydrochlorothiazide, and lisinopril. On physical exam, blood pressure is 210/120 in the right arm and 180/100 in the left arm. Pulse rate is 118, respirations are 20, oxygen saturation is 97%, and the patient is breathing on ambient air. The patient is diaphoretic and in distress. Cardiac exam reveals tachycardia with 3 out of 6 diastolic murmur along the upper left sternal border. Lungs are clear auscultation. The remainder of the exam is unremarkable. Emergency CT imaging confirms the diagnosis of ascending aortic dissection. Referral for the emergency surgical consultation is obtained.
Okay, so now just go ahead and text IMEHRA 720 to 22333.
Is
And
it
then
everybody or just the medical students?
everybody, what, it's just a text.
Why can't you want the number though?
I'm sorry? It's on an app. If you have Poll Everywhere, use the app. If you want to text, IMMEHRA.
So what's the username?
Just use your text and type, oh, you're on Poll Everywhere? The username is IMEHRA720. Okay. Now, whenever you guys are in, just choose your, yeah, perfect. Just text A, B, C. Esmolol, hydralazine, nicardipine, and nitroprusside. They have 5 responses.
Which one is saying the poll could not be done?
Can you just text on the number?
That's what I'm doing.
It's IMEHRA 720 to 22333.
22333.
There are more than 9 people in this room. Come on, Dennis.
Thank you.
Almost 30 people in the room.
You can check everyone's phone.
11. I'm feeling like the car will be like my car scene and then he'll be like, why not?
Or why?
Or why? Or why Esmolol? Alright guys. I'll wait for about 1 more minute and then we'll reveal the answer. Okay. Everybody seems to be off their phone. So I'm just going to go ahead and move on. Alright guys? Everyone done? Okay. Not everyone did it, but it's okay. Alright. So majority, like we can see, chose 16 people chose Esmolol as the answer. Let's see if that's the right answer, okay? Yay! Good job! So it is the right answer. It has a very rapid onset of action, 1 to 2 minutes. It will rapidly reduce your heart rate and blood pressure and reduce the aortic wall stress and limit propagation of dissection. The reason why nicardipine and nitroprusside are not the right answers is because in absence of beta blockade, any vasodilator therapy induces reflex activation of tachycardia and worsens the shearing force on the aorta. Alright, this is the next question.
Is it in practice though, is Esmolol the recommended agent or is it the Betalol?
Esmolol is also equal. I mean, you can use either. Both are very much accessible. Okay, guys. Harrison. Go for it.
A 52-year-old woman is evaluated during a follow-up visit for hypertension management. She has a 10-year history of type 2 diabetes. Diabetic retinopathy was diagnosed 1 year ago. She also has obesity and hyperlipidemia. Medications are hydrochlorothiazide, metformin, empagliflozin, and atorvastatin. On physical exam, blood pressure is 138/86. Other vital signs are normal. BMI is 32. The remainder of the exam is unremarkable. Labs creatinine is 0.9 milligrams per deciliter. Electrolytes are normal. Urine albumin creatinine ratio is 550. Estimated GFR is greater than 60.
So which of the following is the most appropriate treatment for this patient? A. Amlodipine, B. Labetalol, C. Doxazosin, and D. Losartan. That was quick, guys. 8 people.
10, 11.
Yeah.
That's the right answer.
You have another feeling? Okay. All right, guys. Okay, so looks like we have our 16 responses for the day. Let's see what the right answer is. You guys can treat hypertension. Congratulations. So the key point in this question is the patient had diabetes, the patient had hypertension, the patient had proteinuria greater than 300, and that's where your ARB is your choice of, ACE or ARB are your choice of drugs in that situation. All other drugs are effective in lowering blood pressure, but in these comorbidities, those are just preferred agents, okay? And the last question of the day.
Question, before you get to that,
Yeah.
on this last one.
Yeah, sure.
Okay? So was this lady managed appropriately before she even got to you? So she comes in, and you looked at her, what she was being treated with, based on what she had, was she being managed appropriately?
No.
No, of course not. Why? Why was she not being managed appropriately?
She was benefited from ACE arms
A long time ago, how do you know that?
with the diabetes.
Because she has retinopathy, right?
retinopathy.
So albuminuria is a sign of what? Shit in your endothelium, right? Your endothelium ain't working anymore. It's leaking. So if it's leaking in your kidneys, it's leaking in your eye. If it's leaking in your eye, it's leaking in your kidneys. So if they saw that she had diabetic retinopathy, you got leaky capillaries, right? Your little bridges that are holding things together aren't working so well. She should have been on a RAS blocker a long time ago, right? So part two of the questions, assuming she was on a RAS blocker, whether an ACE or an ARB, she comes in, now she's got significant proteinuria, right? She's got 500 micrograms of protein. What's the other step? It isn't just give you an ACE or an ARB. What should we also be doing for her?
Titrating
Well,
diabetes.
I think she's on an SGLT2, right? She's on empagliflozin. So, yeah, so at least you're thinking that way. So that's right. What else? What else? If this was your mom, your...
protein.
What's that?
Check the total protein destroyed.
No, you don't have to.
Like
If you've got a microalbumin to creatinine ratio of greater than 300, you got problems, right? She doesn't have macroalbuminuria yet. She's close. But what should we be doing for her other than an ACE or an ARB?
You need stricter glucose control, right?
Yeah, sure. You always want that, right? But what pharmacologically should we be doing for her? Student Scott.
Stop the medication.
Well, she's on. Well, she's on an SGLT. No, GLP doesn't. It doesn't actually. GLP-1s have a minor effect on proteinuria. So that's kind of a right answer. What's the big drug though that we want to be using for this now?
Do you use explain
So aldosterone blockade, right? So we know that thiazides don't do that. So you could consider taking her off the thiazide and putting her on an aldosterone blocker, right? Either spironolactone or what's the new one that's right. So she really she'd be a candidate for Kerendia, right? So she probably should be on Kerendia. You can either choose to.
If she's already on like losartan, like we were expecting.
That's okay. You just have to monitor potassium. But again, if I had 500 micrograms of albumin in my urine, would I be on that? Then I would. Because that can significantly drop those numbers. Okay.
How does that help, Dr. Hollis, with proteinuria?
Pardon?
How does the aldosterone blockade help with proteinuria?
Okay. That gets us into a whole other question of things, right? So, I don't know if you want to listen to me for a minute, but So if you look at all the big blood pressure trials that told us how to treat high blood pressure, basically in the 70s, the 80s, and 90s, in all our big blood pressure trials, how many drugs, on average, you enroll people in a blood pressure trial, how many drugs on average does it take to control blood pressure?
2, 3,
4.
5, I'm sure.
So on average, in the big trials that were done in the United States, different from country to country, because of different populations, but in the United States, in the United States population, 3.5 drugs, on average, were needed to get people to blood pressure control, okay? Taking all comers, okay? Some trials showed 3, some trials showed 4, but on average, it takes 3.5 drugs. How is that important to us? So, patient comes in to see us in clinic. We put them on one drug. How likely is that going to be effective for them? So you really have to give proper expectations to patients to begin with. I'm going to start you on this medication, but we're going to probably have to add more, because otherwise patient comes back to you in a few months. Hey, my blood pressure's not at goal. And you give them a second agent. They come back in a couple months, they're still not at goal. You give them a third agent. They think you're a shitty doctor. Right? How come we've been here 3 times, my blood pressure's still not where it needs to be? So you have to give them reasonable expectations. And you say, okay, so why? We've got all these great drugs. We're blocking the RAS system. Why is it taking those many drugs to control? Any thoughts?
Because each drug can only reduce it by certain number of pressure.
So that's true. If a patient comes to you, I give you a maximum dose of lisinopril. I put you on an ACE inhibitor, give you a maximum dose of lisinopril. What is your angiotensin II level going to be in a week? No, it's going to be low, right? That's what I'm blocking your angiotensin system. So if I give you an ACE inhibitor, what's my angiotensin going to be? Yeah, really low in a week. What if I check that same patient's angiotensin level again in 2 months? It's back to where it was before I started treating them. What the hell is that all about? What's going on there?
Tachyphylaxis?
Well, it's not really tachyphylaxis. Yeah, there's all kinds of compensatory enzymes, right? So what are ACE inhibitors really? Do they work by inhibiting, well, they're ACE inhibitors, but do they work by reducing angiotensin levels?
No.
No, they don't. They do initially, but what's really going on? What are those drugs really? They're bradykinin drugs, right? They work by raising bradykinin levels secondarily, right? So bradykinin level, and what does bradykinin level, or what does bradykinin do? It's a direct vasodilator, right? So you're really giving a direct vasodilator. So, but if I give an ACE inhibitor or an ARB, what goes up? What goes up?
Your angiotensin.
Renin, right? Because renin's the feedback loop. So you're giving stuff that's initially lowering angiotensin, raising bradykinin, but in the end, renin levels go up. So why is that bad?
Because you're not completely blocking the
More
RAS.
attention.
Yeah, so renin is also a vasoconstrictor, right? Renin also does what to, what's the other bad actor that renin does?
Sodium.
Raises aldosterone, right? So when your renin levels are up, then your aldosterone levels go up. We're kind of setting ourselves up for failure. So what's resistant, hypertension expert, what's resistant hypertension?
It's the use of 3 antihypertensive medications inclusive of a diuretic. And the blood pressure still remains uncontrolled despite.
Right. So despite adequate therapy, which is usually considered 4 drugs, I'm not at goal. Okay, that's resistant hypertension. You see that a lot in clinical practice. What's going on here is probably, again, it has to do with feedback loops, and we're not accounting for that. Okay? So what's our drug of choice? for resistant hypertension. Spironolactone. So that's, again, when you see those people come in, they're resistant to 4 drugs, almost always. Put them on spironolactone. Now, if that doesn't work, then they got secondary hypertension. There's something else we missed. We missed their sleep apnea. We missed their true hyperaldo, which by probably the most common cause of secondary hypertension is unrecognized hyperaldo. When you take away the obstructive sleep apneas. Sleep apnea is probably the #1 cause of secondary hypertension, right? Big part of the population has that. A lot of those people haven't been diagnosed. So make sure when those people come in, look in their throat, look at their Malapati score, get a sleep study.
We have a guest lecture.
Oh, I'm sorry. I'm very sorry. I start rambling, and so again, I hate to do that, but just again, kind of clinical practice. Make sure give patients realistic expectations. Okay, tell them, hey, this is going to take more than 1 or 2 drugs, oftentimes. Okay. Sorry.
No, that's, I'm actually.
No, I'm sorry. I get in here and start rambling. The students
But
will tell
thank
you
you
that.
so much, everybody. I hope you guys learned something.
Very, very